So good morning, everyone. Thank you for joining today's community forum. My name's Miranda Smith. I'm a project coordinator at the Doherty Institute and will moderate this morning's session. We begin by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people joining us this morning. So we have three expert panelists with us today who will address all your questions about COVID-19 vaccines. But before we begin the sort of formal introductions, I just wanted to run through a couple of brief guidelines. So this is set up as a regular Zoom meeting. As I mentioned before, you're welcome to have your cameras on or off, but please keep yourself muted unless you're called to speak. And I will be muting you if I hear any background noise. As I mentioned before, we are recording the session and we'll be posting the link online later for viewing. And if you have any questions for the panelists, I ask that you either enter them in the chat session or when we get to the point where we can get interaction, you're welcome to use the raise hand function by clicking the reactions icon down the bottom of your Zoom window. We'll begin with some of the questions that were posted during the registration. And then we'll move on to questions that you have now. So we've got three fantastic panelists with us today. And I'll start with a brief introduction of all of them, and then I'll invite Tania to say a few words before we move on to questions. So our first panelist is Professor Tania Sorrell. Tania is the director of the Sydney Institute for Infectious Diseases at the University of Sydney. She has a long-standing interest in the prevention, diagnosis and treatment of infectious diseases, and especially in immunocompromised individuals. She's been involved in establishing and leading several national research collaborations, including Beat COVID, funded by Snow Medical, and two NHMRC Centres of Research Excellence, CREED, the Centre of Research Excellence in Emerging Infectious Diseases, and the Australian Partnership for Preparedness Research on Infectious Disease Emergency, or APRISE. Our second panellist this morning is Professor Sharon Lewin, who's the director of the Peter Doherty Institute for Infection and Immunity. Sharon is an infectious diseases physician and a scientist internationally renowned for her research into all aspects of HIV disease and pathogenesis. And she's the lead investigator of APRISE, the Australian Partnership for Preparedness Research in Infectious Disease Emergencies, which has focused on pandemic preparedness in Australia since 2016. Amongst many leadership and advisory roles, she also co-chairs the National COVID-19 Health and Research Advisory Committee. And our third panellist today is Associate Professor Nicholas Wood, who's the Associate Director of Clinical Research and Services at the National Centre for Immunisation Research and Surveillance, or NCIRS. He leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital at Westmead. Nick is interested in maternal and neonatal immunisation, as well as research into vaccine safety, including genetics and long-term outcomes of adverse events following immunisation. So thank you to all three of our panellists. And now I'd like to invite Tania to say a few words about the session before we move on to some questions. So thank you, Tania.
Thank you very much, Miranda, and good morning, everybody. It's a pleasure for us to be here as part of this forum to interact with you today and to try and answer your questions. I wanted to just give a little bit of background as to how we came to this time today, and that is because of a really important grant from the Snow Medical Foundation to this entity called Beat COVID, which you would have heard Miranda mention. It's a large research grant that was really given to us right at the beginning of the COVID pandemic to kickstart some really important research into critical gaps around public health, understanding COVID, and providing information and samples on which research can be done to answer some of the questions that we're going to be addressing with you today. One of the key things in relation to this grant was that it included the APRISE and CREED CRE populations that Miranda has referred to, together with a couple of additional people from the University of Sydney who are interested in new types of adaptive clinical trials, which are much more efficient than our standard clinical trials, and creating large data banks for imaging to help make more accurate predictions and diagnosis around the impact of COVID on different body organs. Particularly, though, I would like to draw your attention to our advisory group, because that's where we met with Janelle Bowden, who is the consumer representative on our group, and she's been really instrumental in setting up today's meeting. So thank you, Janelle, and I'll now hand over Miranda to distribute the questions for us.
Okay, so thanks a lot, Tania, for that introduction. So we're going to start with some of the questions that are that have been submitted during the registration process. I can see that there's some questions coming through in the chat, so that's great. If you do have additional questions, you're welcome to raise your hand or put additional questions into the chat box. So many of the questions that we had in the beginning were around the vaccination of people with immunocompromising conditions. So I might start by asking Sharon if you wouldn't mind reflecting on the issue of vaccination for people with immunocompromising conditions. And particularly there was a question about people who are on endocrine therapy for breast cancer, who are considered severely immunocompromised and requiring a third dose of a COVID vaccine. And the question is, what's the latest data on the need and the effectiveness of a third dose for people who are immunocompromised?
Thanks, Miranda. And you can hear me okay? I'm just using some speakers here. Quite a complicated area, because immunosuppressed is a vast range of different conditions. And the recommendations from ATAGI are based on the evidence we have for different conditions. And not all immunosuppressed conditions affect all parts of your immune system. And that can confuse people, because they think, oh, I'm on a specific agent, therefore I'm immunosuppressed. So the evidence is very clear that 2 doses is insufficient for people who have an immunosuppressive condition that affects their ability to respond to a vaccine, meaning making antibodies. And that a third dose significantly increases the number of people that can develop antibodies by about 50%. And that third dose should be given between 2 and 6 months after the second dose. So when we're talking about population boosters or third doses, these are all given 6 months after the second dose. So the first thing is immunosuppressed people get a dose that's earlier, between 2 and 6 months. And there's a definition of what immunosuppressed means in the ATAGI guidelines. And for example, solid organ malignancies like breast cancer is certainly on the list, but it's solid organ malignancies when you're having chemotherapy or radiotherapy. So endocrine therapy specifically doesn't immunosuppress you. Endocrine therapy specifically acts against the tumour, which is driven by hormones. So I don't think endocrine therapy would be considered an immunosuppressive condition. Of course, now this is a little bit academic, because in the end, everyone's going to get a booster anyway at 5 to 6 months after your second dose.
Excellent. Thank you for that response. And I can see that someone is, there's apparently in the advice from ATAGI, endocrine therapy is on the list of.
Okay, thank you. I'm surprised, but it's that you've got to go back to the list, because they do vary. But, okay.
And I can see Susanna Morris, you've got your hand up, which in relation to this question. So I'd like to invite you to follow up.
Thank you very much. Yes, it was my question. I'm actually a consumer representative who's worked with Cancer Australia on their advice for people with cancer, and I'm working with Breast Cancer Network Australia on writing their advice as well for people. And we were very surprised to see that ATAGI put endocrine therapy on there, but the Lancet article that they referenced is quite clear about people who are actually taking hormone therapy. It's not just women with breast cancer, it's men with prostate cancer as well, showed an immune response after a second dose, which was not dissimilar to those people on chemotherapy. Now, there's been very little discussion of this. Breast Cancer Network Australia have obviously added this to our advice. We're trying to raise awareness of this issue, but I'm not seeing, I mean, in the fact that you weren't even aware of this, is concerning me, which is why I asked the question about what's the further evidence, is this message getting out there, and so on.
Did anyone else on the panel want to comment on that?
Yeah, no, I was unaware of the paper in Lancet, and just for first principles doesn't make sense to me, but you're always happy to be proven wrong. Yeah, it does make sense to me because endocrine therapy doesn't immunosuppress you, but I will look into it and see if I can find more information.
Thanks, Sharon. Okay, well, look, we might move on. The next question that was raised was whether people who are immunosuppressed, whether they can have a different vaccine for the third dose. So I don't know if Sharon or Nick, if you would like to address that.
Yeah, maybe Nick. Go ahead, Nick.
Yeah. So it's a bit tricky, isn't it, really? Because there's third doses and there's booster doses. So a third dose, as Sharon mentioned, is for the immune suppressed. Those people that we think probably need a bit of a top up after their second dose. And we do this all the time for kids, for example. You know, kids get 3 doses of tetanus vaccine as their primary schedule at 2 months, 4 months, and 6 months. So that's sort of the primary schedule. And general rule is if you've had, Pfizer for dose 1 and dose 2, then you should get Pfizer for dose 3. If you've had AstraZeneca for dose 1 and dose 2 and you've not had any problems, you could continue to have AstraZeneca for dose 3, although ATAGI is suggesting perhaps move to Pfizer for that third dose. There could be some benefits in the what we call the mix and match type schedule. So because you're, in a sense, getting 2 different styles of vaccine, 2 different platforms, you might well get a different response. And you know, because you're a bit of a different part of the immune system might well get produce a better response. And some of the mix and match data from the primary schedules has suggested that it is slightly better. So if you've had 2 Pfizers, get a third Pfizer. If you've had 2 AstraZenecas, you could get either Pfizer or AstraZeneca for the third dose. However, you need to check with your doctor to make sure you've not got a contraindication to either of those conditions, those vaccines.
Great, thank you, Nick. So we might just stick with the issue of vaccination of immunocompromised participants at the moment. There's a question in the chat from Adrian Boots regarding the recommendations for long-term immunocompromised patients, such as transplant recipients, and whether in that group there'll be a need for ongoing boosters beyond the current one, and whether, what evidence is being generated to support those recommendations.
Well, I'm happy to address that. So there's 2 issues with transplant recipients that just might be worth highlighting. So people that got vaccinated before a transplant and then get transplanted need to have a complete new course of vaccination. So that's because you've basically wiped out your immunity for post-transplant and you start again. People that have been vaccinated post-transplant and are on immunosuppressive drugs, we know that those are the people that really make the poorest responses to a COVID vaccine. And therefore, the third dose significantly increases the chance of finding antibodies, but it doesn't generate antibodies in everyone. There's some discussions around the need for a 4th dose for immunocompromised patients with severe immunosuppression like post-transplantation, but those recommendations have not come in here as yet. What research is being done? There's a number of observational studies, so people that are following closely different immunosuppressed patients, observational studies similar to what's been reported in the international literature. I know of 2 studies, for example, that are happening in Melbourne. I'm sure Tania and Nick can talk about others around the country. The real issue is about the vaccination schedules and how to do the dosing, and whether it's 3 doses or 4 doses, and timing. And there's very high interest in doing those interventional studies. We may have missed the boat now in Australia because boosters are rolling out. And in fact, there was a call from the Australian Research Funding Agency, one of them, it's called the Medical Research Future Fund, on this specific issue. And this is a bit of a problem that we have in Australia, where you announce a call for research. We've been trying to overcome this a bit with a prize and with Beat COVID, where we can mobilise money quickly. But it's an interesting example. The call for a research study, which was 4 months ago, hasn't yet been announced. In the meantime, the policy's changed. So we need to do better in Australia how we actually do the studies, but I'm not aware of any interventional studies. It's been quite hard to do interventional studies with vaccines in Australia because of access to the vaccines.
So I could perhaps just comment a little bit too, in that there are a number of studies looking at the immune response itself to COVID in immunocompromised patients. And as Sharon has said, a number of us have been involved in grant submissions, which we're waiting the result of, and it would have been nice if they'd come up a little bit sooner. But in Sydney and in Melbourne, and I think in other cities as well, people are very interested in the complete elements of the immune response. It's been mentioned that antibody responses, although improved with a 3rd dose in immunosuppressed patients, are not perfect. But in some of those patients, there is evidence that the other arm of the immune response, that is to say the cell-mediated or T-cell-mediated arm of the immune response, has actually been generated. And so what we can't say with confidence, but there is a lot of work going on, is to say whether or not having one of those arms revved up is actually better than not. In other words, we need to look at the range of the immune response rather than just the antibody response. The other issue with some of the observational studies that Sharon referred to, of course, is that we now are reaching very high levels of vaccination, including in immunocompromised patients, and we're doing some follow-up over time of a number of cohorts of patients to see if they do get new infections or not. So actually looking in real time, if you like, or real life, to see if there's any actually recrudescent or new infections developing. And so far, as I understand it, and Sharon or Nick, you might like to comment further, there's a relatively low proportion of people who have been completely vaccinated who are actually coming down with new infections.
Did either of you want to comment on that?
Oh, no, just to support what Tania said, the effectiveness of the vaccine against serious disease like hospitalisation and death, even in the Delta period, the variant strain that we see now, is still very, very good. So that's really important, that part of the puzzle.
Thank you. So we might move on to some of the other questions around vaccine side effects that have been raised during the registration process. And Nick, I know obviously the National Centre for Immunisation Research and Surveillance is heavily involved in monitoring vaccine side effects. Maybe you could just provide a little bit of a background on how vaccination is tracked in Australia and the safety and surveillance that exists, the systems that exist?
Yeah, sure. So I think we're in a really good position in Australia. So we have 2 sort of basic systems. One is what's called our passive surveillance system. And what that means is that you, the person who has a reaction, can report it to the TGA or your state health department. And clinicians who see people that have had a reaction are also able to report. And in fact, in some states, they're actually mandatory reporters. So they're required to report any reaction they see. So that's the passive system, and all of that data feeds through the state health departments and then on to the TGA who looks at any safety signals. And then each week on a Thursday, the TGA publishes their weekly safety reports. So you can, if you're really keen, you can go onto the TGA website, just type in TGA weekly safety report into your Google, and you should see it there every Thursday. The other system we have is an active surveillance system, and we call this AusVac Safety. And what it is that people who get a vaccine are automatically enrolled into this follow-up system where you get sent a text or an email around about 3 days after each of your doses, and then again at day 8 and then at day 42. And some of you may have been part of this system. We've now got data with over 4 million people who've responded to these surveys. So it's quite an extraordinary system. So again, if you just type in AusVac Safety into the Google, all one word, AusVac Safety, I'll try and put it in the link. You can see the data there displayed, and it's displayed by type of vaccine, so Pfizer, Moderna, AstraZeneca, displayed by dose. And now we're getting more rich data, so we're able to look at people that have cancer and how they've side effect profile, and particularly look at adolescents as well. And so we know a fair bit of how these vaccines are performing in the real world. And it seems very similar to what we saw in the trials. Pfizer dose 2 is more reactogenic than Pfizer dose 1. AstraZeneca dose 1 is more reactogenic than AstraZeneca dose 2. And Moderna dose 2 seems to be the most reactogenic. And the sorts of things you're seeing are headache, fever, chills, malaise, injection site pain, and these are the common side effects that we see. So two big systems, an active system called AusVac Safety and a passive system. So there's a question there about how did you end up on the AusVac Safety email list? So it really depends on where you got the vaccine. So if you were, and it also depends on where you live. So in Victoria, they have a system where it piggybacks automatically off the back of, it's called a vaccine management system, and it piggybacks automatically off the back of different vaccine GP clinics or council clinics. In New South Wales, we had the large vaccine hubs out at our Olympic Stadium, etc., and people were enrolled into that. You can get it through your GP if your GP is a member of AusVac Safety. We're linking through to pharmacies now that are giving Moderna. So there's a lot of work that's gone into linking this SMS delivery system to the site where you're actually getting the vaccines administered. So that's the sort of in a nutshell. Now, AusVac Safety has been around pre-COVID. This was set up, more than 5 years ago. And it's been looking at flu responses, HPV, the Gardasil type vaccine responses. So been around for a few years, but it's just become extraordinarily bigger because of the COVID vaccines.
Thanks, Nick. There was a question that sort of follows on from some of that, which is what's going to happen to all of the reported vaccine side effects? Is there an ongoing analysis and reporting of because often there's concordant issues that occur that may not actually be vaccine related, but are time-wise related to vaccination. And what happens with all that data?
Yeah, so the ones that are serious or they're new or that are unusual are usually looked at by the state health authority. So in Victoria, you may have heard of SafeVic. In New South Wales, the state health does it. In Western Australia, there's a setup called WAVS, South Australia has a setup called SAVS, and these are all vaccine safety surveillance systems. And what they do at the state level, they will look up serious, unusual cases to get a bit more information to see, was there an alternate cause? Was there another cause for this particular reaction? And all of that data is then fed up to the TGA. Now, if there really are significant events, the TGA sometimes convenes a causality assessment panel. So that's a group of experts that will look at the case in detail and try and work out whether this vaccine was causally linked. Now, this has become more and more important because you've probably seen in the media, I don't know, Australia now has a COVID vaccine claims scheme. And you can type that into Google. And if you think you've had a reaction, you can now register your interest to find out some more about the claims scheme. And it seems about 10,000 people have already put claims in. Now, that doesn't mean they're all going to be funded for, get compensation, because each of those will need to be looked at to see, does it meet certain criteria, which we don't quite understand yet from the government, how that claims scheme will work. So yes, they do all feed into the large body of evidence so that we know this is how vaccine with this particular strain works. When we move to giving, say, variant vaccines in the future, we'll have a baseline to look at to see, does a booster dose with a variant strain give you a different side effect profile, if that makes sense. So we've got a baseline to get off. Remember, these vaccines have only been around on the planet for just over a year or so. And so we don't have a lot of experience with them. So it all feeds into what we're doing nationally is being done by many other countries as well.
There's a question that's come up in the chat, which is a slightly different, sort of looking back at more basic issues around vaccination. And the question is, do we know all the reasons that the Delta strain has taken over? Is it all explained by its relative greater transmissibility, or is it also related to previous immune responses to Wuhan type viruses?
I'm happy to answer that. Don't think I could say we know all the reasons that the Delta strain, and you'd never get a scientist saying you know all the reasons, but there's no doubt Delta is more transmissible because it creates more virus in the nose. So we know for many other infectious diseases, the amount of virus, if you've got more virus there, it's easier to transmit it. And so there's definitely more virus in the nose for Delta. And viruses it's evolution of the fittest. And if you've got a survival advantage, like you can infect more people, it will take over. Are you more susceptible to, does a prior Wuhan infection give you some protection against Delta? Yes, it does. Does it give you as much protection against Delta as a vaccine? No, it's probably about 20-fold less protection from prior infection. So most of the people, and there's a lot of studies of that, as we've seen different waves of viruses spread around the world, many people that were infected, I get this question asked a lot because, I had COVID last year, do I need to get vaccinated? And the answer is definitely yes, because your protection against infection with Delta is substantially increased with vaccination and much better than prior infection. You get some protection, but not complete protection. Not as good protection.
And there was a question presented during registration, which is a little bit related to that, which was what the thoughts are on the idea that mass vaccination for COVID-19 could potentially precipitate the beginnings of another strain of virus that might be more damaging. So what's the impact of vaccinating such a large proportion?
We don't know the answer to that, but if I was to predict it, the more people you vaccinate, the less likely you have a chance of a new virus emerging that's resistant to the vaccine. It's when you have partial vaccinations, so that you've still got a lot of, only half the community vaccinated and half the community infected, then you've got a chance potentially for evolution. But viruses evolve, and they evolve in the face of different pressures. But if you have very high levels of vaccination, you reduce the chance of transmission, so that you reduce the opportunity for that virus to evolve. Because every time it infects a new patient, the new person, it's got a chance to change its genetic code. You reduce that way down. And actually, interestingly, COVID's not a very variable virus. So I've spent most of my career working on HIV. HIV is about 100 times more likely to mutate than COVID. The problem is that COVID has just infected so many people. So widespread vaccination will greatly reduce the chance of a variant emerging.
I think Sharon's comment about is really important, because it's what we're very afraid of for developing countries in particular, where there's really rapid spread and the opportunity for large amounts of virus to multiply. So in the overall scheme of things, there's a mass multiplication of virus. And as Sharon said, every time it multiplies, it potentially mutates. This is a form of virus called an RNA virus, where these mutations, which really mean the genetic code is not perfectly reproduced, as well as it is with some other viruses or other infections. And that's how these variants emerge quickly. And there are a lot more of these changes or mutations actually occurring in these viruses than we see the end result of, because many of these so-called mutations are in parts of the virus where it doesn't really matter. It doesn't actually affect the transmissibility of the virus. It doesn't affect its ability to cause severe or less severe infection. But absolutely, high levels of vaccination, most unlikely to amplify the problem.
Thanks, Tania. I'm going to change tack a little bit. There was an interesting question from Elizabeth Vinken in the chat about infection during the vaccination program. So if someone gets infected with COVID before their second dose of vaccine, how long do they need to wait after their infection to have the second dose of vaccine? I don't know who wants to tackle that one.
Yeah,
Nick?
so you should get the second dose, and the rules will say you can wait up to 6 months, defer up to 6 months. So the question then is, do you give it at 3 months, 4 months, 5 months, or 6 months? And I don't know if we have a definite answer to that. I think what we've been saying to people is make sure you've completely recovered from your COVID infection and wait a little bit more after that. So that's probably a bit of a, but you do need, like Sharon said before, you do need, even though you've had the disease, you do need that top up of the vaccine-induced immunity. So definitely wait till you're completely recovered, and then a little bit more will be my advice on that one.
Thanks, Nick. And there was a related question, which is asking about the difference in immunity from vaccination and infection. So the question from Janelle is that she's heard that it's said that if you're vaccinated, you have better immunity than if you've been infected with COVID. Is that true? And if so, why is that the case?
Yeah, I don't want to get into too much detailed heavy-duty immunology, but it's related to the amount of antibody and the quality of the antibody and the durability of the antibodies. And that's all related to how your body responds to an infection and establishes what we call memory. And even though the vaccine just immunizes against one little part of the virus, spike protein, but if you have an infection, you make an immune response to all the virus. It seems that in the vaccine, with some vaccines, probably mRNA the best, you just have higher antibodies. They're better quality, meaning they just recognize more types of virus and they last longer. Actually the best combination, but don't try it at home, is infection and then vaccination. You seem to have the best response. And I'm still waiting to see the data from vaccination and then breakthrough infection. But so all of this is just around educating your immune system to recognize that piece of the virus. And mRNA does it really, really well. And the best studies, so we can study the immune system to death and know about the quality and the quantity and the durability and which cells. But I think the really best evidence is the clinical evidence when you look at your risk of infection. And that is your risk of infection if you've had your risk of getting reinfected if you've had infection before is reduced compared to if you've never been infected, but your risk of infection after vaccination is far greater, reduced by about 20-fold. So vaccination does a better job. Not many things in nature humans can do better, but in this case, vaccination does a better job.
Thanks, Sharon. I'm going to change tack again and go to a question that was submitted in the registration process about the Novavax vaccine. So Tania, I'm wondering if you can tackle this one. When is the Novavax vaccine going to be available? And could you tell us a little bit about the Novavax vaccine and its safety and efficacy? Because there's a lot of interest in when that might become available as an additional option for vaccination in Australia.
So my latest information is that the vaccine is still under review by the TGA. The expectation has been that it would be available in Australia in late 2021. It clearly is now late 2021 and it's not available. I think there have been issues not only in the TGA ensuring that they're confident in all of the data, but that the manufacturing has run into some difficulties in that scaling it up for the large amount of vaccine production has hit some hurdles and has slowed things down a little bit. This vaccine is different from the mRNA vaccines. It actually contains the spike protein or manufactured spike protein itself rather than the instruction to a cell to produce the spike protein. And that's contained in a little tiny nanoparticle, which also contains material called an adjuvant. The adjuvant's important because it amplifies or stimulates the immune system to generate a much better response to the particular protein. In relation to the question about safety and efficacy, we don't really have long-term safety data and efficacy data yet. There have been two large studies, one in the US and Mexico, which had 30,000 participants, or nearly 30,000 participants in it. One in the UK where there are 15,000, and there are some additional studies in South Africa with smaller numbers and elsewhere. To date, those studies have not revealed any significant serious or have not revealed serious side effects. There have been the usual, what Nick had referred to as reactogenic side effects. That's the early ones with perhaps fever, sore arm, feeling unwell, feeling very tired. But even with that number of patients or people that have been immunized, we can't confidently say that there won't be a rare side effect. If you consider AstraZeneca, for example, the chance of death from the clotting disorder is about 1 in a million. So this number of patients or individuals that have been studied is relatively low, and we have to wait and continue our close observation to be confident about whether or not there are some rare longer-term side effects.
Thank you for that, Tania. There's a slightly different question here from Mason Littlejohn, and he's referring to the fact that influenza vaccines rely on a globally coordinated surveillance and research network, and whether there's anything in the making for COVID, whether we'll end up with national WHO coordinated COVID centres. Does anyone want to comment on that? International surveillance?
Yeah, I'm happy to respond, but not sure I can provide more insights for Mason. At the moment, the COVID genomic sequencing is a little ad hoc, meaning that different countries have different partnerships, high income and low income countries which are doing the sequencing. I'm not unaware of a systematic approach from the WHO to set up global sequencing like we have in other infectious diseases, not just influenza, but I'm sure we'll see that coming.
Thanks, Sharon. Another question here is regarding people coming into Australia with recognised vaccination certificates. What should be the requirement for people getting a booster if they're coming in but have received vaccines that are not registered in Australia?
Yeah, it's been pretty tricky, this one, because the TGA now has a list of recognised vaccines, including things like Sinovac. There's the Indian-made equivalent of AstraZeneca's Covishield. So yes, if you've had one of those recognised ones, you're okay. If you've not had one, if you've had, like, for example, the Russian Sputnik one is not recognised by the TGA, and if you've had that, then you sort of, then when I say not recognised by the TGA, it's because they sort of have not determined whether or not it's efficacious enough for their needs. So you're sort of stuck with saying, well, I've had 2 doses of this vaccine. My options are to go on and get the recognised one in Australia, which many people have done. Not many, but some people have done that. Or you don't, and you just wait till you get your roll around for your booster dose. If you've had it a long time ago and it's now 6 months, I would probably get the booster dose, would be my recommendation there. The other issue is that, as we know, some people require valid vaccine doses for their workplaces, and that makes it a bit more complicated. And we've been asked to write exemptions for people that have had non-TGA approved vaccines, and so it all gets a little bit tricky. So my advice is talk to your local GP or healthcare provider and you work out your own circumstances and why you particularly need that vaccine. But there are people that have had, 2 doses of a non-recognised vaccine and gone on to get 2 Pfizers, and it's all gone well. Does that make sense? Does that sort of answer that one, Miranda?
I think that sounds pretty good. Thank you. We've had some questions both in the registration and now just coming through in the chat about the vaccination of children. And I know this is a particular interest of yours, Nick. So perhaps we'll stick with you for the moment. What's your thought about the vaccination of children under 12? So this group hasn't been approved yet for vaccination. Why should we or should we not vaccinate that group?
Yeah, it's a little bit more complex than the older group, and I've just put in the chat a really nice paper in Archives, which is written by Nigel Curtis from NCIRS, and so it just goes through the things we need to consider about vaccinating the under 12s. What they have done is the vaccine companies have done trials with small numbers, a couple of thousand children under the age of 12, in fact, really only between 5 and 12, and given them a lower dose of the vaccine. So for the Pfizer dose, they dropped it from 30 micrograms down to 10 micrograms. And for the Moderna dose, they dropped it from 100 micrograms to 50 micrograms. So they halved it. And then they go about looking at the safety and immune responses. And it turns out in the 5 to 12-year-olds that the lower doses generate a really good immune response, the same as the older adolescents, even though they're getting a lower dose. And the safety profile in these relatively small trials is also similar to the 16 to 25-year-old age group. So, and as we know, the US has started to roll out the vaccine to 5 to 11-year-olds. Atagi is looking at it right now. My guess is that we'll probably, I'm just going to pick a number, come out early next year as being on a recommendation. The vials are different, and so there's the issue of the supply of those vials into Australia as well. We're competing with other countries again for those particular doses. So yes, I think it will come. It will be this lower dose. Children in general don't get as sick as adults, which is a good thing. They still can rarely get sick. They can get this unusual inflammation response many weeks after the disease. And they can also get long COVID, which is, ongoing symptoms. But they're just in general, fortunately for us, they just don't get as sick as the older adults. So when you're weighing up the benefits of the vaccine, you've got to think about how sick the kid will get if they got the disease. And there's also the role of what children play in the transmission of the virus. We know from schools work, looking at transmission in schools in New South Wales and in Victoria, that in general, schools are pretty safe places. We don't see a lot of transmission. The main place for transmission is in the household. So I think it will come. It will be a lower dose. We will continue to monitor the safety of it, and probably early next year is my guess. I don't know if Sharon or Tania want to say anything extra. But...
No, that's a great summary, Nick. I agree that it's not as straightforward as the adult risk benefit, but I see benefits, and we'll learn more and more, of course, as many other countries are ahead of us on this.
Yeah, I agree.
Thank you, everybody. The next question is about mRNA vaccines. There's a question in the chat about the manufacture of mRNA vaccines. So, at the moment, we don't have the capacity to manufacture mRNA vaccines onshore, but there's a lot of investment to ensure that that will come online soon. So if we and when we do get that capacity, what other viruses should we be looking at for vaccine development?
I'm happy to take that. Well, mRNA vaccines could work against any infectious disease. It's just the way we present a part of the virus or the bacteria, so the immune system recognises it, and mRNA does it very efficiently. The real beauty of mRNA is that all you need is the genetic code of the virus or the bacteria to make your vaccine, which is why Moderna and Pfizer were able to make the COVID vaccine so quickly. So I know that, the story of mRNA is very interesting because it started with vaccines for HIV, which have been very, very tough to make. And there will be studies of mRNA with HIV, but I'm not so optimistic it will solve the HIV problem because in the end, you've got to really understand what immune response you need, and tricky viruses like HIV are not straightforward. But for infectious diseases that we have not such great vaccines with and know the immune response, so influenza, mRNA is being evaluated, RSV, respiratory syncytial virus, a very common respiratory disease that largely affects children, is being evaluated, anything, TB, malaria, Ebola, they've all got mRNA vaccine studies either in the pipeline or being done right now. So we're likely to see, if we can also make it cheaper and easy to transport and available all around the world, mRNA may change the face of vaccination. Of course, we've got some vaccines that are brilliant vaccines and super cheap to make. Hepatitis B is an example. There's many examples. Not much driver, but for the vaccines for the areas that we don't have a vaccine or we have a pretty crappy vaccine, then mRNA I predict we'll see a lot more in the future.
And Sharon, you probably know more of the history than I, but I think it's fair to say the concept of mRNA vaccines is not as new as you might think it is. It's actually been around for a while, and there were a lot of effort put into making an mRNA-based vaccine in SARS, which was back in 2003. And it wasn't actually proceeded with, basically because SARS disappeared. So although we think of it as a very new technology, it's actually been in development for quite a long time.
Yeah, the first, I'd recently heard the inventors of the BioNTech vaccine speak. It's Katie Carrico and Drew Weissman, and their landmark paper was in 2000 on mRNA. And the trick was finding the type to modify the mRNA so it didn't hyperstimulate the immune system, and that was in 2000. and they tested it in HIV, and yeah, so it's been around for a long time. But the big clinical trials, you know, how quickly this moved gives us incredible information now that it's here to stay, I think.
Thank you for that response. And Nick's put a resource in the chat that explains how RNA works, a piece in the conversation. So if people are interested, you might want to go and have a look at that. We're coming towards the end of our time. I just wanted to go back to the issue of side effects, because there was a question in the pre-registration about side effects and reactions to third or booster doses. And there's been another question in the chat about people who are reluctant to get a second dose of vaccine when they've had a reaction to the first dose. So I guess, you know, together these two questions, you know, what's known about reactions to third doses or booster doses of vaccines, and what are the recommendations when someone's had a reaction to a first or a second dose? What's the reaction about the recommendation, sorry, for a subsequent dose?
Yeah, so in terms of your reaction after dose 1 and whether you should get dose 2 or not, you're probably best to talk to your individual circumstances to your GP or healthcare provider, because there aren't too many what we call true contraindications to getting the vaccines. Things like anaphylaxis are, or this rare clotting syndrome. Of course, the other one that we are seeing a little bit with the mRNA vaccines is the heart inflammation, which is known as myocarditis. And so if you do get this, then after dose 1, then you definitely need to talk to your GP, and then there are guidelines that exist about what to do for dose 2 in those people. And if you've had your 2 doses and you had a reaction after dose 2, and then you're wondering what to do with the booster dose or the third dose, the same story. Just get it looked at so someone can say, well, this is exactly what your reaction was or was not, and this is what we can do for your next dose. The safety of the third doses, we don't know anywhere near as much as we do now after dose 1 and dose 2, because we've given 19 million doses in Australia and hundreds of millions around the world. So we know pretty well dose 1, dose 2. Dose 3 data is coming out. From the trials, it looked very similar to somewhere between reactions to dose 1, dose 2 sort of level. Ausvax Safety has got some data out there already on that. It will continue to monitor those. It's not an exponential, not an increasing reaction with each dose. Dose 2 seems to be the most reactogenic, and dose 3 not too bad. A few of my friends have had quite large lymph gland swelling after the vaccine, in the same arm that they got it. So, that's it's a common side effect, I think, that we'll probably see. So, no, not too worrying, the third dose.
All right, thanks a lot. We might, I know there's still questions in the chat that we haven't addressed, but I think we're not going to be able to address everything in one session, and we are coming to the end of our hour. So we might stop the questions now, and I might just ask Tania if you would say a couple of concluding remarks for today's session.
Thanks very much, Miranda. I think one of the things that we can follow up on the unanswered questions in the chat, assuming, Miranda, that you have the email addresses of the people that have asked them. So don't feel that you won't be able to get an answer. I would like to thank you all for your participation, and I think the questions have really been very helpful for us to hear, so that we know how to respond to, but also how to pick up any gaps in what you've identified for us that we need to follow up from a research point of view. I think the other thing that I would just say is that we are always keen, as we develop new projects out of the Beat COVID and continue the Apprise and other research programs to have consumers who are willing to be part of a co-design of some of the research that needs to be done. And so if you have found this session valuable and you would like to potentially be contacted to either assist in development of research plans or participate in them, then via Miranda, we'd be delighted to hear from you. So thank you also to the panel, and in particular, Miranda, thank you very much for your fantastic chairing of the panel. We hope perhaps that we can have another one of these. It obviously won't be before next year. We do understand that a number of people wrote in to say they would like some more information about long COVID. And so let's think about that for the new year. Thanks again.
Excellent, everybody, and thank you very much. Have a good rest of the day.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.